Good afternoon, everyone. Today, my topic is pain abdomen in children, a clinical approach to diagnosis. The most common causes of pain abdomen that we see in our clinic are constipation, gastritis, gastroenteritis, urinary tract infection, appendicitis, intussusception, intestinal obstruction. Now, the very important thing is how do we differentiate from malingering or acute pain abdomen that is chronic and something that needs to be treated. So very careful clinical history is very important here. How the symptoms started, how long the duration has been, where does the child say pain? Does the child say, they have abdominal pain as soon as they wake up in the morning, after they defecate, after they have their breakfast or lunch, or is it just before going to school? These are some of the important things that we need to ask in their history. And a careful examination has to be done, taking the child into confidence so that they are not traumatized with the experience. The other important investigations that we need in evaluating pain abdomen are an X-ray, an ultrasound abdomen, and a CT abdomen, if required. So how do we go about is one is we ask the child to tell us about the location, how often the pain is, the frequency. Is it there every day? Is it there throughout the day if it is there every day? Is it associated with meal times or any other particular episodes? What kind of pain is it? How severe is it? Is it a kind of a colicky abdominal pain, or is it a constant pain, a stabbing kind of pain, a burning sensation? So we need to evaluate the different qualities of pain in the child. And then we need to look for associated symptoms. Is there a fever present, nausea, vomiting, loose stools, constipation, history of constipation, and in the order in which these symptoms started. This is very important in trying to differentiate what's causing the pain in the child. A gentle approach is very important because the child may be distressed. It's always best that once you expose the abdomen of the child, you ask their permission first. The child lays down on the examination couch. The child shows their abdomen. Usually, as per dictum, you're asked to bend the knees, but in a child that reduces your space for examination. So I prefer to have the child extend their legs, and I would like the child to point out the site of pain, and then observe the child while they point their site. Look at the breathing. Are they holding their breath? Is there any distension? That is, can you see the costal margins or not? Are you able to see any visible loops of intestine or any masses that you can see? Warm your hand up if it's your hands are cold because you're sitting in air conditioning the whole day. And then examine the child by palpating with deeper and deeper with each inspiration. And look at the child's face while you're talking and try to distract them. Ask them non-relevant questions or even questions relevant to their pain. And look for any voluntary guarding and try to differentiate between voluntary guarding and guarding because of the pain. Rigidity would mean diffuse pain and the child holding the abdomen completely tight. And rebound tenderness has to be also elicited. To elicit rebound tenderness, what we do is release the hand suddenly, and then they have to tell us if the pain is more when we are palpating or when we are releasing the hand, and that's how we elicit rebound tenderness. And you can also look for the wincing of the child's face when you're examining for rebound tenderness. A sudden wince is also a very early sign of acute appendicitis, and that would help us guide in the plan of management. An X-ray abdomen is a very important investigation in trying to evaluate pain abdomen. You need to look for the normal gas pattern. Usually in a normal gas pattern in a child would be a stomach gas shadow and a cecal gas shadow. You may have colonic gas or gas because of constipation or loaded colon. That would help us in evaluation. You can look at the flank stripe in a child in the abdomen, and this is the flank stripe. This is the layer between the peritoneum and the abdominal muscle. And this is usually well maintained in a healthy child. But sometimes if there's any evidence of peritonitis, that could be edematous, that layer, and the flank stripe will be disrupted. This particular X-ray is an X-ray of a child with acute appendicitis. But as you can see that the flank stripe is not disrupted here. So we are looking at a very early appendicitis in the child without evidence of local peritonitis. The second X-ray is a child of very dilated gross bowel loops, and this is a non-contrast film. It's a plain X-ray. The child had very severe intestinal obstruction. As you can see that it even has elevated his diaphragm, and there is some evidence of free air outside the lumen also. So again, very important diagnostic tools. Ultrasound is another important investigation, but it is extremely user dependent. So you have to have confidence in your radiologist, somebody you can communicate with on a regular basis, so that helps you with your diagnosis and treatment. As you can see that the first ultrasound is a classical picture-in-picture evidence of intussusception. Very common problem we see in our clinic, especially in the rainy season when the viral infections increase. The second film is one of acute appendicitis. You can see an edematous blind ending tubular structure, and if it's not compressible, even with compression with the ultrasound probe. Again, these are some things that are very important to look for on ultrasound guidance. This is a CT abdomen. We usually recommend an evaluation of plain abdomen, especially if the child's symptoms are equivocal, where we are not able to decide whether only medical management is sufficient or whether the child needs surgery or not. And especially a child who continues to have symptoms, but no direct clinical evidence suggestive of peritonitis or localized plain abdomen that needs further evaluation. This particular child had a pelvic appendicitis, as you can see. The appendix is in the pelvis. It's quite dilated and edematous, and which we were not able to elicit through the ultrasound or via clinical examination. And the next thing that we will be looking at is the common causes of plain abdomen. Constipation is one of the most common complaints. Very typically, the child would give a long history of constipation. The pain is usually directed to the left iliac fossa or the pelvis. There will be history of passing large hard stools, passing stools very infrequently, maybe history of passing stools at the end of the day instead of the beginning of the day, maybe an episode of acute fissure in ano. Very typical behavior of in younger children to stand while defecating or trying to postpone defecating by all these dancing maneuvers. It's very important to ask the parents what kind of stool they have by looking at the Bristol stool chart. Very important to see if they may say that the child is passing stools every day, but if they have a type 1 stool, the child might pass frequently multiple episodes of small quantity of stools, but would never completely evacuate their colon. So it's very important for the parents to see the kind of stool that the child is passing so they can help with the child. And the second important thing is take an X-ray abdomen, because that gives you, the volume or the severity of the constipation. So then you can sit and plan what kind of, management you need to do it. Do you need to plan a disimpaction? Do you need to plan an enema regime for the child to, treat their constipation? Or can we start with oral laxatives? And the laxatives have to be, very importantly, that the dosage of laxatives has to be titrated for each child. Some children respond to a very small dosage of laxative. Some children need higher and higher dosages until they defecate at least once a day comfortably. The laxatives sometimes may be required in very high doses in children, but that should not be a deterrent in trying to increase the dosages. And these laxatives are continued for a short-term duration, at least of 3 to 6 months, until the child is able to make all the behavior and dietary changes. And laxatives should not be stopped suddenly, because that will cause a very severe rebound constipation, and we are back to the same original history of pain abdomen again. So very important to educate patients about the dietary and behavioral history that comes along with constipation and dysfunctional elimination syndrome that they have. The other common pain abdomen complaint that children complain with is epigastric pain. This is usually indicative of some sort of acid peptic disease, most likely gastritis. The child gives history of waking up in the middle of the night with pain abdomen. It's usually associated with either before or after eating. It's located around the epigastric or umbilical region. Occasionally, it radiates to the back. The immediate treatment would be pain relief for the child, temporary bland diet, no irritants to the stomach, such as spices. Some children drink tea and coffee, none of that sort. And to give PPIs or antacids. But for immediate pain relief and succor, I would recommend that the child should use Gelusil or sucralfate for a short duration of a week, 10 days. And to continue beyond the symptom relief, because it has to allow the inflammation and the ulcers to heal. and then we can slowly get back the child onto a regular diet. Again, very important to evaluate pain abdomen when the child has gastroenteritis. Not all patients with gastroenteritis may have loose stools, but some may present with severe abdominal pain. They may have distension, tenderness, and voluntary guarding, but there'll be associated high-grade fever, which is not very typically seen when you have a surgical cause of pain abdomen, such as appendicitis. An X-ray and an ultrasound would guide us, but these children have to be managed conservatively with medical management. Urinary tract infection is another common cause of abdominal pain. A child may not always complain saying that they have pain or burning micturition. They may have hypogastric pain, which may be intermittent, may be associated with voiding. The child may have associated constipation as it's a part of dysfunctional elimination syndrome. The associated constipation has to be treated, especially when the child has recurrent infections. The clinical examination also should include examining the external genitalia. In a male child, they may have phimosis, and a female child may have labial adhesions. And these need to be treated to prevent further repeated episodes of urinary tract infections. Any child who has a febrile culture positive urinary tract infection, they need a screening ultrasound and evaluation if these repeated infections are happening. This is first picture is a typical child with labial adhesions. These adhesions need to be released. We usually give either Vaseline or Avalon, that is estrogen cream, local application. And we also have to educate the parents regarding chemical irritants to the genital area. There are certain parents who try to use wipes or chemical disinfectants in the external genital regions, and we do not recommend that they use anything. Just plain, simple water is more than adequate to maintain hygiene in the external genitalia. For phimosis, we try to use a local steroid ointment that can help loosen the skin. If there is no scarring, it gives wonderful results, and we can try to avoid circumcision in most children. Acute appendicitis is what most parents are, one of the most common surgical problems that we see in the clinic. Most parents come with the complaint of the child has right iliac fossa pain. Now, the very important thing is to differentiate whether this is acute appendicitis or is it a medical issue. Usually the pain starts, a child complains of pain abdomen around the periumbilical region. It may gradually localize to the right iliac fossa. The initial symptoms would include nausea, lack of appetite, and sometimes low-grade fever. When there is severe right iliac fossa pain with a high-grade fever, usually that is associated that this appendicitis has progressed into a perforated appendix and that needs urgent admission and treatment. If the appendix is pointing towards the pelvis, a child with acute appendicitis may even present with loose stools and occasionally burning micturition also. The walk of the child is again very important because a bent over gait or a fixed flexion deformity is very important in guiding us that this child may be having an acute appendicitis. It's very important that when we examine the child, that we examine slowly from the left iliac fossa, gradually proceed in a clockwise direction and examine the right iliac fossa at the very end. And with each palpation, we deepen it only with each breath of the child. We should elicit rebound tenderness, and any diffuse tenderness with diffuse rebound tenderness may indicate that the child is also having associated peritonitis. A CBT is very important. We should grade acute appendicitis using the Alvarado scoring. That would include the scoring system where we score for the migratory pain abdomen, rebound tenderness, neutrophilia with left shift of the neutrophils, and also associated fever and rebound tenderness. In ultrasound abdomen, an appendix that is more than 6 to 7 should be considered for surgery. Anything that is less than 5 mm in diameter, it's most likely a benign one, and these children can be managed conservatively. If children are still having acute pain, but their neutrophil count, their WBC count is not very high, and their abdomen is quite soft, a CT abdomen may help guide us in deciding what form of management we should consider for this child. A simple plain X-ray can help us when for these two investigations are not available. Some of the things that we should look for is a local air fluid level. Sometimes a fecolith that is there may be visible. There may be a loss of the flank stripe in the right iliac fossa for these children. Medical management in should be considered in patients with equivocal signs and symptoms. Laparoscopic appendectomy is usually the go-to method for doing appendectomy in children. It is even, it's actually very useful, especially in the more complicated appendicitis, such as perforated appendicitis, retrocecal appendicitis. It actually is a very good method of doing appendectomy. This is a very classical inflamed acute Most children can be discharged within 24 hours of admission if they present an early appendicitis. And those children with perforation may require a further admission for a few more days to help them recover from the effects of appendicitis. Intussusception is the other most common, second most common problem we see in our emergency. A typical child is of 6 months to 2 years. The mother would complain that the child would have had a recent viral infection, such as a cold or a loose stool episode. The child is having colicky abdominal pain where the child is sleeping between the episodes, and the child is usually has sometimes a soft abdomen if they present early. They may or may not have a mass that is palpable. Sometimes they may have jelly-like stools. They may be associated with vomiting or distension. The ultrasound is very typical with a bowel-in-bowel picture, and usually intussusception that is ileocolic is the one that is symptomatic enough for us to plan reduction. Small bowel intussusception such as ileo-ileal or jejunal is usually self-limiting and can be just managed conservatively. Very rarely we'll see colocolic intussusceptions. They usually have an underlying pathological issue for that. What we do for our children who present to us with intussusception is hydrostatic reduction with ultrasound guidance and occasionally CM guided. We have the child in the emergency. We have an associated radiologist, and we infuse saline via the rectum with a Foley's catheter from a height of 1 meter. And we make sure that the perineum is trapped. And we continue the inflow of the saline until we can see the intussusception reduced. The intussusception how do we identify it? Is when we see free flow of fluid through the ileum between the ileocecal valves. There may be edema at that region, but that is the usual way of saying that we have reduced the intussusception. But post-reduction, the child should be observed because in recurrence of intussusception is very high in the first 24 hours. And slowly we allow the child with clear fluids after 6 to 12 hours, sometimes after 24 hours, depending on how symptomatic they've been. In case of perforation or irreducible intussusception or recurrent intussusception, we can plan surgery for these children, either a laparoscopic surgery or an open surgery. This is a typical open surgery of a child with ileocolic intussusception. This is the apex of the intussusception, and this is the small bowel that is all the way up to here. And this is, we press from here and reduce intussusception completely. The other important things are to rule out, the most acute ones are the intestinal obstructions. These children present with abdominal pain. They may have bilious vomiting. They may or may not have abdominal distension. Especially if it's a high intestinal obstruction, they may have copious amount of vomiting, but no abdominal distension at all. Some children on examination may have visible palpable loops and very severe tenderness of the abdomen along with distension. These are images of some of our recent patients. This is a child with a Meckel's diverticulum presented with massive GI bleed. This is an image of a child who presented with acute intestinal obstruction. This is the X-ray that we saw earlier with massive dilated loops and feculent vomiting. This child had a duplication of the jejunum along with a perforation. And this is the duplicated jejunum. And there's the ulcer in the small bowel for this child. So again, very important that diagnosis is picked up early. Children may present with shock because of massive third space loss. Surgery. Once we establish good urine output, the vitals are stable, then only we should proceed with surgery for these children. Other causes of pain abdomen where we are not able to differentiate is very important to again have a very good clinical approach. In dengue, a lot of children present with diffuse abdominal tenderness, distended abdomen, very severe tender abdomen, but it's very important that not to diagnose peritonitis in these children and do surgery because they'll have a very, very poor prognosis. They may have multiple fluid collections in multiple compartments. So it's very important to differentiate dengue from other causes of acute abdomen. In severe pneumonia, occasionally children may present with pain abdomen. Mesenteric adenitis is a very common diagnosis that we see in our children, But this is not to be, this is not a worrisome diagnosis. The child can be managed conservatively. Parents have to be reassured about the mesenteric lymph nodes. These are usually present in any kind of GI infection, and they need to just be treated with either symptomatic medications. Occasionally, children can present with severe acute pancreatitis. They'll have very severe abdominal pain that radiates to the back. These children can have retching or sometimes even non-bilious vomiting. And this needs complete evaluation because pancreatitis in children can lead to quite a lot of serious complications. Thank you. Any questions? So one question that was asked was, what about fat stranding in acute appendicitis? That is a question that a radiologist would be better to answer, but that's usually indication that the fat is inflamed and edematous. So that's how you see fat stranding in acute appendicitis. And that's again an indication of inflammation in that region. So that should be part of your evaluation to see whether this child needs surgery or not. The medical management of acute appendicitis would be to start the child on antibiotics. If they're able to tolerate orals, you can put them on either a soft, bland diet or oral liquid diet and observe them. If the child's symptoms worsen, such as they have vomiting or fever, then definitely the child needs admission with IV antibiotics and IV fluids. Some children, the pain is quite severe, but either the white cell count is not very high, or the ultrasound or the CT are equivocal, then these children should be admitted NPO for at least 24-hour duration, along with IV antibiotics and reassessment again after 24 hours. There's another question about labial adhesions and phimosis. So for phimosis, what I usually recommend is Betnovate ointment, or any steroid ointment that you're comfortable with, but not with added any antibiotic, just a plain simple steroid ointment. I would advocate the parents to use it 2 times a day at the tip of the penis. 15-day duration is more than adequate to cause loosening of the prepuce. And the prepuce should be retractile completely to the groove, so then the parents can maintain the local hygiene. Now, most parents stop the ointment when the prepuce opens up a little bit, but that is not adequate. It is important to see not only the meatus, but also see the glandular groove. So then the parents can maintain local hygiene and prevent recurrence. Labial adhesions, we usually do a separation either in the clinic or if the child is not cooperative in the operation theater. And we usually apply local non-adhesive ointment. We suggest either Vaseline or coconut oil to be applied there. Sometimes we recommend estrogen creams, but that has to be used very judiciously. You cannot overuse estrogen cream in a child, so it's very important to do that. And we again observe these children. A lot of children come back with recurrent labial adhesions. Again, very important to tell the parents not to use toxic chemicals in that region, either like Dettol, antibacterial soaps, or use Surf or Dettol for treating the undergarments of these children. Again, it's very important. There's a question saying, how do you differentiate intussusception for distal intestinal obstruction syndrome caused by cystic fibrosis? I think an ultrasound is good enough for us to differentiate because the bowel-in-bowel picture is very classical of intussusception. Distal intestinal obstruction caused due to a mass impaction or because of meconium kind of alveolus will have air fluid levels and bilious vomiting, which is again very different from the picture in bowel-in-bowel picture that you would see in an ultrasound. There is a question saying, when do we go for surgery in ultrasound reported appendicitis? Again, very important that we don't diagnose appendicitis just on one investigation. It is the complete picture, the clinical history, the examination findings, along with the CBP report, the white blood cell count, and then the ultrasound, is important in trying to, guide us to a good diagnosis. We don't treat patients on investigations, we treat the child. So even if a child may have had history or an ultrasound suggestive of appendicitis, but if the child is completely normal at the time of diagnosis with soft abdomen and no further symptoms and is tolerating orals well, there is no harm in continuing a medical management in such children. Significant submesenteric adenitis, I really don't know, because most mesenteric adenitis is probably associated with a viral or a bacterial infection, maybe a recent gastroenteritis episode. So unless we're suspecting something more in a child, and especially if the pediatricians have completely investigated, then only we would say that mesenteric adenitis is significant, maybe an associated lymphoma or some other associated pathology. Common causes of abdominal pain is mesenteric lymphadenopathy. Yeah, very common. Don't really know why children have mesenteric lymphadenopathy. It could be because of a viral infection, any GI, as we know that most children, the most common source of viral or bacterial infections is through the oral cavity. So this is part of developing the immune system. So I think unless mesenteric adenitis is a part of an associated syndrome where we are worried about the size of lymph nodes, and I would say here mostly lymphomas, then I would be really concerned about the size of the mesenteric lymph nodes. Now again, mesenteric lymph nodes can cause a dragging type of pain in a child and maybe localized pain in the right iliac fossa. So symptomatic treatment, antispasmodics is a good one for intestinal pain, because anti-inflammatories don't really work on the small bowel. It's very important to give antispasmodics because it's the smooth muscle of the small bowel that is the either the distension or the contraction that the child is responding to. There's a question saying, till how many hours can appendicitis be treated with IV antibiotics and when to decide for surgery? So now that you have diagnosed acute appendicitis, that is either through your clinical examination, investigations, and you have planned that this child needs surgery, then the scheduling is up to you. One is important to see the fasting status of the child, because acute appendicitis is not something we rush to the OR immediately. We keep the child NPO, we make sure that the child gets a good dosage of antibiotics, and then we can plan for the surgery. We can plan it add it on to our elective schedule also. It's not a surgery that we would say that you should come at any time of the day or night and do it. It is important to get the surgery done. It is important to plan it at the convenience of the child and the surgeon involved and the OR team. There's another question about how important is the size of lymph node in mesenteric adenitis. Personally, that is not something that would really come in my sphere. I would suggest that, that is something that we should discuss either with the infectious disease person or a pathologist. There's another one. Do labial adhesions without history of UTI need to separate? Yes, they should, because most mothers are very concerned about labial adhesions. And what happens in labial adhesions is the child voids from a small opening somewhere near the clitoral region. And this causes a lot of pooling of urine in the vagina. And this can cause foul smelling in the genital area. So labial adhesions should be separated because that helps maintain hygiene of that location. Severe epigastric pain persisting despite hospitalization for 3 days, that child needs evaluation. Maybe I would suggest that these children need NPO for a couple of days until their symptoms are better. A little rest of the gut is very important in managing a pain abdomen. Which antispasmodic is better, Drotin, Anafortan? I would leave the choice to the treating doctor, whatever you're comfortable with. That is the drug of choice, because you should be comfortable with the medication that you're using. Is surgery indicated in acute appendicitis immediately after diagnosis or managed conservatively at an elective date? Well, acute appendicitis is an emergency, but like I said, it's not an emergency where the child has to be rushed into the OR immediately. The child definitely needs to be admitted, treated with IV fluids and IV antibiotics, and the child also needs to be planned for surgery as soon as possible, but not at a time like, say, at midnight or very, very early morning, unless, that's when the scheduling happens. The chances of recurrence of intussusception following hydrostatic reduction, it's quite common. Within the first 24 hours, the chances of hydrostatic reduction, intussusception recurring is very, very high. So that is why the child is usually observed for 24 hours after hydrostatic reduction before we discharge in our hospital. But usually once the intussusception is reduced, most children do not get intussusception again, but it can happen. Buclizine pain abdomen, not quite sure. I've not used that drug. Role of probiotics, again, not quite sure, but a healthy diet, well-rounded nutritional diet is very important. If you actually see most of our children, an associated acute abdominal pain would be associated with a recent party over the weekend, a birthday party where they've eaten a lot of junk food. So again, educating the child or, for the pain, the good dietary habits are very, very important. How common are renal stones in your practice? We do see renal stones. Again, renals, we are in the part of the stone belt, part of the Deccan Plateau. Because our water here is the hard water, so we are prone for renal stones in this area. So we do see few children with renal stones, and it's very important to diagnose. And we do stone removal in our hospital for children also, including ureteric stones and renal stones. MRI versus CT, I would recommend CT because one, for diagnosing acute pain abdomen, and the other thing is that in a MRI abdomen in a child, the child would need to be sedated or under anesthesia, and I wouldn't recommend that unless it's absolutely important for diagnosis. Can we give NSAID to reduce appendicitis? I would recommend paracetamol, and paracetamol works well because it's a good, it helps reduce the inflammation and treating acute pain abdomen. So yes, paracetamol is part of the treatment in treating acute appendicitis. So creams using estrogens, I would recommend a very short duration, about 15 days to 1 month under supervision, and make sure that the parents discard the tube because usually the tube is a very large tube of estrogen. So I would recommend the parents discard the tube as soon as our course of treatment is open. And the parents should continue to apply Vaseline at the labia for at least a few months thereafter because recurrence of adhesions is very common. Again, very important to educate the child about voiding on time, defecating regularly, and also eating a healthy diet and drinking adequate water. Very important in preventing labial adhesions. Importance of gallbladder sludge in acute abdomen. Again, it's usually associated with a child who's had a recent septic episode. So we would like to monitor the sludge because if the sludge is persistent and the child has associated jaundice, then we would need to evaluate for acute, any CBD kind of obstruction. Gallbladder stone of 2 to 3 mm size, I would recommend observation and waiting. Unless there are multiple calculi, then you need to evaluate for a hemolytic disorder that comes under more a pediatric purview. Role of PPIs in gastritis and how long we should continue. I'm not sure about the current guidelines, but I would continue for at least 15 days after the acute episode because that would give adequate time for the, the ulcers or the inflammation to heal. So we should, treat it adequately in these children because stopping it for a very short duration, they'll come back with symptoms and again and again. And so it's very important that PPIs continued for at least 15 days from the acute episode. Rectal analgesic anesthetic creams, that would be when you're dealing with constipation and fissure in ano, and I think that's a completely another topic. When to suspect abdominal compartment syndrome in dengue, I think is when you have a very hemodynamically unstable child and a very distended abdomen. But seeing abdominal compartment syndrome in dengue is actually very rare. It's mostly because the child has, other hemodynamic issues from dengue that you see in abdominal distension. I don't think the kind of abdominal distension or, dilatation of bowel that you see will cause abdominal compartment syndrome in dengue. Any drugs for treatment of stones or gallbladder stones or surgery? Only if the gallstone is symptomatic in a child that we recommend surgery. Otherwise, sodium acid is used, but how effective is it? Don't really know. What needs to be done for labial adhesions, because it's very common recurrence? Yes, I agree, it is very common, but it's important to educate the parents here. I would recommend that they use only water to wash the perineum of the child. They do not use wipes. If they can, and for undergarments, I would recommend any clothes that touch the genitalia, I would recommend them to use a mild bathing soap for washing, not to use strong detergents, because all these it can cause a dermatitis kind of reaction at the labia. This kind of causes ulcers and then causes the labia to fuse. So it's very important that, the parents are educated regarding good hygiene practices, but not to use chemicals in cleaning the external genitalia of these children. Parents nowadays, with all the television, exposure, they think that the body has to be sterilized, and we should educate them that that is not a good practice. Role of dill oil, fennel oil, I'm sorry, I've never used. I do not know. Any more questions? Great. Thank you. Thank you for